Hi, and welcome. So this is the TRT and Hormone Optimization YouTube channel, and we have a new guest today, Dr. Andy Tomlinson. Welcome, Andy.
Thanks for having me, Stephen.
Hi, man. So maybe since you're a new guest, let's first start by introducing yourself.
So my name's Andy. I've been a doctor for almost 10 years. I've been involved in TRT for coming up to 5 years now. I work in the UK. I've treated hundreds of patients, probably about 500 by now. So I'm well versed in what the TRT journey looks like, a lot of what's out there. I really like clearing up some of the misinformation that's out there for patients. And that's really what I like about it. I'm helping in a different way that's not really provided, helping people improve their lives, giving them good advice and providing safe practice, really.
Mm-hmm. Great. So I gathered some questions from our Facebook group and under other YouTube videos. So let's start with those questions, and if people are watching, they can leave their questions in the chat box. So let's just take whatever here. A very general question, of course. Will TRT solve all my libido issues?
It's a good one. Yeah, potentially. If you don't have testosterone, that will affect your libido, most likely. So but you need more than that to have libido. So if you've got to have a partner you're attracted to, you've got to have other lifestyle things that are addressed as well. You may or may not have other comorbidities going on that are affecting it. So if you're feeling generally unwell, you're probably not going to have much of a libido. That's not commonly what I see. Most commonly what I see is just men, often with no other health conditions, with low libido secondary to testosterone. And in those patients, it does work. But the one thing to think of is a lot of people, when they start testosterone replacement therapy, expect it to be like an on-off switch. So I take it and I'm better. And sometimes it takes a long time for that to happen. So you can end up with a lot of symptoms of low testosterone. So you can have, you're losing muscle mass no matter what you do. You're gaining body fat. You can have psychological symptoms, you're very stressed, things like this, brain fog. And those improve at different rates. So sometimes what I've seen is I've got all this muscle mass back and I feel sharp, but the libido's not there. What's going on? Or the other way around, the libido comes back, but nothing else. And that's the one thing you're not really in control of at the start. You've kind of just got to be patient with it and just wait to see what happens. And I often tell patients, don't really have any expectations for 6 months. Often you get some benefit a lot faster than that. But I think 6 months is a good benchmark. And that lets us take into account your bloods and get everything right, because we don't always get it right at first. Sometimes your levels are too high or too low, and both of which can give you symptoms you don't really want. And the other thing with libido is just go into it relaxed and just don't have any expectations of the treatment. Just see what happens. I think if you're always anxious about something, that will also tank your libido significantly as well.
Mm-hmm. Is that one of the most common low T symptoms you hear men complain about? Low libido?
It's up there, but funnily enough, the thing that bothers men more than low libido tends to be this tiredness. So they're saying, like, I'd like to have libido. I find my partner attractive and all of this, but I'm so tired. I just want to feel not tired first, then I'll worry about the rest. Which logically makes sense, really. But libido is a very, very common one, yeah. And different people are in a different stage of the relationship or in different kinds of relationship where a low libido can be life-ruining, really. It could end marriages and things like this in some cases. Other cases, partner's not really that bothered and they just want the partner better. So that's where the tailor-made approach and taking people's own lifestyle into account comes in.
Sure. Yeah, some people want their libido back. Others just think about the gym, building muscle. So the next question was about that. What's the best anabolic TRT dose for muscle growth?
So, as you know, as a doctor, it's a difficult one to just sort of answer without being like crucified by your colleagues. So, What I say is our job is to get your levels safe, and the rest is up to you. That doesn't mean So some people, they'll see a health practitioner and they get their level just 1 point above the minimum and are told they're fine, and then their symptoms are ignored. That's definitely not my approach. I definitely aim for the upper third of the normal limit, keeping an eye on things like your hematocrit and stuff like that as well. So obviously safety is a concern, but we want it as high as possible, giving the maximum symptom relief, but also being safe. That's paramount. In terms of muscle growth, the rest of it's down to your own lifestyle. Are you eating right? Are you training right? Are you doing all these things sensibly? And then I don't see any reason that if your testosterone's normal, you can't gain a significant amount of muscle mass. You can get extremely big by just training right and eating right. And I think looking for a high number for performance enhancing and things like that, the safety issues far outweigh those benefits long term. Yeah. So there's a bit of a roundhouse answer to that, really, isn't it? I think we just need to look at what's safe and pay attention to your symptoms, basically.
Yeah. The other question was also in relation to what you just said. Some people ask, do I have to diet and work out on TRT? Because that's that's an advice we give very often.
I mean, yeah, because you're looking for TRT for lifestyle optimization. That's it. I don't feel good. I want to feel better. And so I would say the best way to feel better, and it's free, is looking after yourself properly and exercising. And I would say anyone, no matter who you are, needs to do that. And most of the patients seem to get that. I mean, for TRT, they're all men. Most of them want to be fitter and stronger. That pretty much is the driving force for them seeking help. So I don't find that a difficult discussion to have. There's only a couple of times where patients have put up resistance to it. But I do make clear that I expect you to live a healthier lifestyle than perhaps most people. I do expect you to stop recreational drugs completely. They definitely contribute to lowering your testosterone. If you drink too much, I do expect you to stop drinking or be completely in control of that. Some people don't think they binge drink, and it doesn't actually take that much alcohol to binge drink. And it's pretty easy to reach, say, 40 units a week without trying that hard, especially if you go out and drink socially. It can be done. So I am quite clear with those patients. I expect you to stop doing that. I expect you to take steps towards stop smoking and vaping and all of this, and just live a textbook healthy lifestyle. And that's what I think will get the most from it. Because if I've got your numbers right and you're still not feeling good, I'm pretty much out of ideas. There are other things going on that you can sort out yourself, but that's kind of it. TRT is not this silver bullet that will fix everything. It will just fix your low testosterone, and quite a lot of it is up to you, I think.
Mm-hmm. So TRT or HRT is not just the cherry on top. You do expect the patient to do a lot of work themselves.
Yeah, absolutely. I'm pretty clear about that. I'm quite lucky in that most of my patients are pretty keen to do that. Most doctors, when they see patients that perhaps are overweight, they actually don't want to change that, or they're insistent that they exercise when really they're probably not. They don't want to change their diet. Whereas I think most of the TRT community are actually very keen on improving their lifestyle. So that makes my job pretty easy. But I think if we're talking to a wider audience, which obviously this has been broadcasted to, I would say absolutely. And if you're not optimizing that part before you're seeking TRT, absolutely do it. Stop drinking completely. TRT is not something you should be seeking. It's something to optimize your health if you need it. Stop drinking, stop smoking, improve your diet, get a good workout regime going. It doesn't even need to be exact. Just get some sort of weightlifting going. It doesn't need to be advanced. You're not competing, and get some sort of cardio in there as well. And I would actually expect most young men to try and get their lifestyle better, to exercise almost every day. I don't think 5 times a week's a lot to ask for a young man to train. It should really be the baseline that you should be doing something. So most of my patients that have come to me have already done all of this. And to be honest, if you haven't, I would really encourage you to not spend more money and actually try this yourself and come back to me. And I've said that to a lot of patients as well. So yeah, it seems a bit, I don't like to be inflexible as a doctor. I like to try and listen to people, but for that one, that really is a non-negotiable for me. I think you really do need to try.
Yeah, you gave some specifics about cardiovascular and resistance training. But what about diet? What do you mean if you say to a patient, you have to watch your diet? What do you recommend?
I tend not to go into too much in specifics about it, because I'm not an expert, basically. So someone who does one sport will go, well, that diet wouldn't work for me. So if you're an ultra marathon runner, you eat masses of food and you do things differently. If you want to be a power lifter, then you need to adjust your diet accordingly as well. Personally, I'm a fan of sort of low carbs if you can, high protein, high good fats. And I do sometimes tell patients, do your own research, but high protein doesn't mean you can get protein from literally any source and have fun with it. It doesn't mean eat an entire plate of sausages. That's completely different protein source to, say, lean chicken. They're not the same. So you do need to look into what these healthy fats are. You need to look in a bit into your diet and take your own interest, because I don't have the educational background to talk about every sport and the nutrition. It's very specialist. And we'd be here all day if I was going to do that. It's a completely separate topic. So, but as a general thing, I'd say no processed foods. If it's made in a factory, don't touch it. Go get your meat from a butcher if you can. That sort of thing. So you can see what it is. No one's done anything artificial to it. Good amounts of fruit and veg. I know there are some people out there with carnivore diets who are saying fruit and veg is the enemy and things like that. Personally, I think it's pretty good source of nutrition, I think. But like, so that sort of stuff. I mean, if you eat fruit, veg, nuts, lean meat, I don't think you can go too far wrong, to be honest.
Yeah, exactly. A question I had very recently under another video I posted. What if TRT stops working? Someone said, I'm around 1,000 nanograms per deciliter, I guess, and still feel exhausted every day.
So I'd say I want to know how you're getting that blood result. So I need to know what your regime is, how compliant you are with it. Are you really being compliant? And then when you got the blood test, what your free testosterone is. So rather than going around the houses, I'll talk about it sequentially. So you want to know total testosterone. That's very good, 1,000. I think in English units, that's probably around about the 30 mark, upper end of reference range, something like that. So that's a good number. So what are you taking? Is it gels? Are you on gels? Are you on Libido? When was it taken? Are you taking short-acting injectables? If so, what's your regime? Is it into the muscle? Is it into the subcutaneous fat? Are you being fully compliant with treatment? Have you just taken your things leading up to the blood test? Sometimes I've seen this, and this isn't slating one medication over another, but sometimes gels are fantastic at first, and then they're not, and your numbers are fine, and I've got no explanation for it. I've seen it a couple of times, and we're all different, and we're not machines, although we could see it as we are, but sometimes things just don't make sense, and it's no real benefit in looking for the logic there. So I'd say, like, yeah, what are you taking? Could it be working or not? What's your SHBG? So it could be high, it could be low. So for example, if your SHBG is low, you can end up with a high free testosterone, and the testosterone that's too high can also make you feel not so good as well. So and I have seen that. So it can give you kind of similar symptoms, paradoxically, to before you started. So there's that to think about. Then so that's it. Probably best having a chat, really. And also your estrogen is another one I think is important. So estrogen or estradiol, whichever you want to call it. If that's raised, that can give you nasty side effects as well. So you can feel emotional. And if you were feeling a bit anxious before, that will look like it's coming back. And so your testosterone might be too high. We can lower the dose. That would lower the estrogen, and that can help. It just bring you back into range. Your levels just might be too high. So there's a few things you might need. You might need something like an aromatase inhibitor. I've found a short course and stopping helps. I know some doctors just prescribe it you straight away to stop the side effects, but I kind of like estrogen. I don't want you to tank it completely. You need it for long-term health as well. So I think there's so many things going on there, and it's a question I get like too many what if questions, and you spend too long explaining it. I think the best thing to do is see your physician and tell them your symptoms, give them your blood work. And I always ask patients to tell me what your latest regime is, when your bloods were taken in relation. So I've got all my history there. Then I can listen to you and make a make a kind of assumption or something going forward. It's a really big question to answer. So like, that's why we just want the full blood panel. And then along with your symptoms, sometimes patients just go, here are my results, doc. And that is literally the email I get. And it's very hard to interpret that. But the ones who give me lots of detail, you know, with the bloods included and everything, it allows me to formulate quite an accurate management plan for them.
All right. More questions are coming in the chat box, but I have one last general question for you. How to find the best TRT protocol for me? How often do I have to do blood exams? How often can I change dose and injection frequencies? So a very general question, but how to find the ideal protocol for one patient?
I tend just to listen to the patient, what their life looks like. It's as simple as that. So I know there's a lot of stuff out there, like when they say gels don't work, don't ever touch them. No topical preparations. They're all rubbish. That's sometimes what the internet says. And I always tell patients, just hear me out and then I'll listen to you. So I had one patient who was a traveling salesman, for example. They just wanted something to put in their suitcase, no messing about, and that's it. And they're open to anything. Well, gel's quite a good option then, especially if your symptoms aren't like crushing your life. Then it's actually, well, there's some logic in trying it then. You might have mild symptoms. The worst it could do is waste a bit of your time, and it's easy to transport. And if you're traveling a lot abroad, for example, the gel's easy to take with you. If, for example, you've got young children, they're grabbing you all the time and things, and person-to-person transfer is a problem, then probably stay away from the gels. Even some of the reps are saying this. It's just not worth the risk of person-to-person transfer. If you've got a job where you're sweating, for example, then maybe the gel isn't so good for that. But if you've got a clotting disorder, then the gels, they're most gently absorbed. They're associated with less clot risk and things like this. Then I'd say that's a no-brainer that you'd have to try that first. If you don't want to do something every day, then injections are good. Once a week injections, a lot of patients do well on that. I do recognize some don't. Some do get a mini peak and trough. You can do daily if you want, but then you're back to having to administer something every day, which may or may not be something you want to do. I found that kind of 2 or 3 times a week injections for most patients tends to serve them quite well. And if it's, and I know there's 7 days in a week, how do you divide that by 2 or 3? I just say Monday, Thursday for twice a week in the morning, Monday, Wednesday, Friday for 3 times a week. Don't worry about the Sunday. And that pretty much sorts most things out. If you get it done in the morning, you can then get to a lab. You've got many opportunities to get your bloods done, where you can get a trough sample for us to analyze it. So I tend just to hear people out. I explain everything from start to finish, how they all work. I answer any questions you may have come across on the internet in my consultations. And then I'll just talk with you about what you think's best. Most of the time, I want the patient just to be happy. So as long as they've not said anything that's unsafe, I'll totally go with what they've just said. And if you go into your treatment happy, then to me, that says you're going to do the best. You're happy with it. So you'll go into it more relaxed. You won't be as apprehensive. And I think you'll do better.
Mm-hmm. So that answers the first question in the chat box. How many times a week do you suggest one inject? So 2 or 3 times, I guess, is what most people do.
Yeah, 1 to 3 times. I think daily is probably overkill. If you think it works for you, it works for you. It's not something I routinely advise.
Yeah, sure. Have you ever heard of anyone on TRT for years that didn't need HCG, estrogen, and clomiphene or thyroid meds to maintain energy? It seems it's inevitable for everyone. I hate saying everyone, but what's your opinion?
To maintain energy. I think thyroid's a separate thing. So, I mean, your hormone axis in general, all quite sensitive. So if there's no reason that your thyroid can't just give up on you, that can just happen. There's lots of reasons for it, which would be a completely separate topic. So that's it. I think we could park thyroid. I think it's just a separate pathology. If you feel bad, you should just get it checked once a year or something, or keep an eye on it. HCG just maintains testicular function. And in terms of how I practice and my endocrine colleagues and the conferences we go to and things, it does 2 things. One, it maintains testicular size, if that's a particular concern to you. Most men aren't bothered, and most partners don't actually know how big their partner's testicles are. But if it's something that's important to you, crack on. It can cause a disproportionate rise in estrogen that I've seen in some cases. So, more medications, more problems. What do we do with this estrogen rise and things? So when that does happen to my patients, no real dramas. I'm just quite ruthless in cutting the HCG, unless you need it for fertility. So also it kind of continues kind of maintaining testicular function. And should you want to try for a baby, the idea is you come off testosterone, you have a very high dose of HCG, and you just start trying for a baby. When you've got a successful pregnancy, that means you've had your up-to-date scans and it looks like, your baby's going to be okay and everything. You can start your testosterone if you wish. So you don't have to wait a full 9 months to go back onto testosterone. But I've not really noticed anything to do with sort of energy or lack of efficacy over time. That's not really something I've seen.
Do you guys also optimize thyroid, I guess?
I look at thyroid, but most TRT clinics in the UK probably won't co-prescribe the thyroid medication. What I tend to do is signpost to the GP. And over here, it's the GPs are pretty good at prescribing thyroxine. They'll just give it a go. And if it's complicated or anything, they'll refer it to the endocrinologist. So yeah, there's nothing stopping you just having a trial of medication and things with that. But I tend to personally stick with testosterone. It just depends probably on the limit of your own clinic and what the clinic as a whole is comfortable doing. As far as I'm aware, I could be wrong, but as far as I'm aware, most UK men's health clinics just stick to testosterone and managing that. I'll have a look at your bloods, and if I see something I don't like, I'll advise you on it. And then I say, go and see most likely your GP about this, and this. And if they want me to write a quick letter, I will do, and stuff like that. But I think if you go and see a specialist clinic and they start trying to handle too many things at once, there's room for error there, which I'm not really comfortable with. I'd rather get another doctor involved, and I'm more than happy to communicate with them to any level that's needed. But I think that's just a safer approach.
And will you start HCG or Clomid for fertility reasons?
Yeah, so HCG Clomid, yeah, so you can start either. Interestingly, I'll send this to you afterwards. One of the drugs companies has sent something out saying there's a very rare cause of blindness with clomiphene, which has caused me to kind of stop prescribing it. I thought up until then there was just a risk of visual symptoms, headaches, and blurred vision, that sort of thing, that stop when you discontinue the drug. But apparently there's been some case reports of irreversible sight symptoms, which has made me think, right, no, I'm not going near this anymore. We've got HCG, which is perfectly acceptable. If you want to pay for it, you've got recombinant FSH as well, but that costs a fortune. At that point, I'm probably referring you to a fertility expert. But HCG is more than good enough. And as far as I'm aware, very well thought of amongst endocrinologists as a monotherapy if you want to do that. I don't know what it's like in the rest of Europe, but in the UK, that costs quite a lot. So for monotherapy, you're looking at sort of £100 to £150 a month for that. So most patients just go, I'll have TRT and the lower dose HCG. And when the time comes, I'll have it for as short as possible. But I saw a study and it was saying that quite a low dose of HCG actually maintains quite a high intratesticular testosterone concentration. And so that would indicate that your testicles are still doing their job, but with TRT support in the background. So for anyone listening, it's not medical. Basically, HCG mimics something called luteinizing hormone, which is the chemical messenger from your brain that tells your testicles what to do. Now, the reason for that, when you inject testosterone, it gets everywhere in your body except your testicles. And I liken that to you wouldn't deliver cars to a car factory. That'd be pointless. So that's what's going on here. Your testicles have got no mechanism to absorb testosterone. Therefore, they will shut down if you inject testosterone with no other medication. So HCG keeps the factory going, as it were. And in plain English, that means you can carry on with sperm production to some level. And when you want to try for a baby, it's thought of as best practice to maintain fertility. Although I do always tell patients, not absolutely bulletproof, but it's pretty good.
Yeah, right. There was a question. Can you talk about main water retention, bloating, edema on TRT? Is that just a temporary thing? And is there something people can do about it?
tends to be associated with estrogen. That so sometimes you'll see people abuse anabolic steroids and they're massive, right? And they're big, they've got water retention, big muscles and everything. And unfortunately, when you talk about testosterone, they're the sort of things you think of. You know, the old guys who do the pro wrestling or your favorite wrestlers and things like that. But people with TRT, they're just your normal guy walking around. Like if you train on top of it, you'll get the same or similar benefits to if you were just training natural, really. Sometimes your estrogen does come up, because I always tell patients, we're not making you Superman. We're doing organ replacement, and organ replacement's never perfect. Think of somebody on dialysis; it's just less extreme than that. So I say that, well, it's not perfect. Sometimes your estrogen will shoot up in response to this medication. It's all to do with what your body does with the stuff, really. A lot of the time, testosterone gets metabolized to estrogen. So if your testosterone is high, your estrogen will be high. If you lower testosterone, estrogen will follow. And that's normally my first line. If I see your testosterone's high, or indeed your free testosterone. So remember, if you've got a low SHBG, you don't need an impressive testosterone for it to be high. I'll explain what SHBG is later. So let's try and do the least we can first. Let's lower your medication and things like this. If you do get the bloating, your estrogen's very high and your testosterone's normal, that would indicate that maybe we could do something like an aromatase inhibitor and things like this. And so we can give you a short course of that. I tend to just say stick it out for 2 months, 2.5 months, something like that, and stop and see what happens. And weirdly enough, some patients do quite well with that. And I don't want your estrogen to go too low. You need it long term. It's not pointless. I think a lot of men are scared of estrogen because they think, especially if you don't have a background in this, women have that, I shouldn't have it. And that's not quite true. Sometimes estrogen is very high as well. You're asymptomatic, leave it alone unless it's very, very high. If it's very high as well, you might want to recheck the blood test. It's probably a lab error. But if you're asymptomatic, try your best not to do anything. I don't know if that answers that. Let me know if it does, by the way. If you want anything clarified, I sometimes go off on one. So yeah.
Yeah, Andy, I've been using compounded testosterone cream 20% for many years now. I was very good on it from the beginning, and I still am. This gives very stable levels. What's your opinion on it? Do you prescribe it too?
Yeah, it's compounded cream. We use a pharmacist to make it. The only downside to it, which won't apply to the patient that's just asked it, is I need to get the concentration right for you, because it comes out in a metered dose. So it comes out in a 1 ml dispenser, and it's a set concentration. And I can make that concentration whatever I want. The problem is, if it's too high or too low for you, how do I increase or decrease it? Do 1 ml and a little bit? What's a little bit, So that's probably the only downside, which I don't think's a big deal. Really, what that translates to is, I'm really sorry, I'm going to mess you about here and maybe waste a small fraction of your money ordering a new lot next time, something like that. If you're stable on it and your symptoms are free, crack on. Why stab yourself with the needle if you don't need to and you're happy on the medication? If you're happy applying it every day, crack on.
Steve Allen writes, I use scrotal testosterone cream. I have SHBG 60 to 70 nanomoles per liter. I have to get my total testosterone level to 1,800 to 2,000 nanograms per deciliter to get my free testosterone high enough to feel good. Is this okay if labs are good?
For that patient, I would monitor their free testosterone, to be honest. And that's it. Yeah, I have seen some people with very, very high SHBG. 60, 70s up there with the highest that I've seen. If you can get it there and your free testosterone's fine, then fair enough. The one other marker I'd monitor is hematocrit. Be very strict with that. If that starts to go high, me personally, I say 0.54. Different people say different amounts, but it's not much higher than 0.54 that everyone agrees is too high. The idea of that is that you've got clot risk associated with that. So that would take precedent in that particular patient's case. But I've got patients with like testosterone levels that no one would really touch. So if I quote English units here, so about 20 odd, but because their SHBG is so high, the free testosterone's low, so I've treated them. If you want to know in the other units, times it by about 30, multiply by 30, and that will give you roughly the other unit. So yeah, like I would do that. And I tell patients as well to keep very hydrated, at least 2 liters of water a day, because dehydration can result in a artificially raised hematocrit. And if someone sees you on TRT with raised hematocrit, they will really, really knock down your dose and start advising blood transfusions. It will be alarm bells going off. So you really want to stop doing that. And I really tell patients at least 2 liters of water a day. If you're exercising, losing lots of sweat, more than that, make sure your urine's always dilute. This common sense stuff, but you need to be proactive. Otherwise, it's going to affect what doctors advise you to do next.
Another question: what are good ways to lower a slightly elevated prolactin and keep it low?
I wouldn't read into prolactin personally. So it's a weird one, prolactin. The reference range is reasonably low. It's about 300 odd, something like that. If you're in different countries, you use different reference ranges, apologies. But like it's relatively low, and prolactin is quite a sensitive marker. So if you've been ill, if you're not feeling good about yourself, like so many things can raise it. If you've been training hard, a couple of days, even 48 hours before the test, any sexual intercourse or ejaculation 48 hours before the test, an STI, so sexual transmitted infection, or a urine infection can raise it. So if any of that's going on, then that will artificially raise it. What are your symptoms? The thing that worries me about prolactin, do you have a prolactinoma? So that's a tumor secreting prolactin in your brain. That tends to be kind of 800 to 1,000 and climbing. And so if it's just up and it's come out of nowhere, recheck it. I don't always believe you just developed a brain tumor overnight. That's not going to have happened. It might have done if it's constantly rising. Other things that can alter it are mental health medications. You're perfectly entitled to have depression coexisting with your low testosterone, although low testosterone can contribute to depression, but depression is extremely common. So you might be on some antidepressant that can also raise it. So unless you've got something ruining your life with this prolactin, I just wouldn't touch it. There are a lot of doctors out there that prescribe things to lower the prolactin, things like cabergoline and things. Like just look at the side effects of these. They're quite wide ranging. So then what's your plan after you source some of this, whether your doctor prescribes it you or you get it off some pharmacy yourself? Let's face it, some patients do that. What are you going to do now you're taking this? And so I tend not to worry about it. I find that some patients think prolactin, it sounds like the word lactating, and men shouldn't do that. We must lower this. And I can see where you're coming from if you're not medical in your background. That's fair enough. But I think people attribute too much worry to it. Just discuss it with your doctor if you're worried. No one will tell you off to it. But I just want to put people's concerns at rest here. The thing that I worry about, is it a prolactinoma or not? That's like number one. Aside from that, I pay fairly little attention to it.
Yeah, sure. Talking about SSRIs, are there any medications that people can take that lower testosterone? So if you see a man with low T symptoms and he's taking a whole list of medications, are there some that you want them to stop because of that reason?
Number one will be opiates, 100%. Like that they actively lower your testosterone. There's a doctor called Janine David. Feel free, just find her, just harass her online. It's totally fine. No, she gives this really, really good talk on opiates with testosterone. She does it at a lot of the conferences we go to and things. And she's really good at putting succinctly all the causes of low testosterone that are out there, either comorbidities, things like diabetes and stuff like that, and medications with it. I think in terms of medications that will cause low testosterone, I tend to think with patients, are they on too many medications? So like, if you're type 2 diabetic, secondary to your lifestyle, fix your lifestyle. That's it. If I could tell you in one sentence what to do that. There is a good deal of reversibility of type 2 diabetes. And funnily enough, there's something you can look up, the T4DM study. It's a study that in Australia, really good study. Men who are hypogonadal and they gave them testosterone. Long story short, it's shown better diabetic control, in some cases reverse the diabetes. So that's a real summary of it. I've not done it justice, but you can look into it. It's a big study. So while you're on the medications, can you get off it? Are you on statins or high cholesterol, or can you just sort your diet out? Can you train? Can you stop having this? Especially if you're young, you should be able to get off most medications. Again, most men that see me aren't on a huge list of medications. They don't have lots of comorbidities. Most commonly, they've got asthma, basically, and their background tends to be things like trauma. They've been in car crashes, broken bones, that sort of stuff. So it's nothing really that's there. There's some stuff that can contribute, things like hemochromatosis. So for anyone who doesn't know, it's an iron storage disease. You accumulate iron basically anywhere, in organs, heart, kidneys, that sort of stuff. Long-term, it interferes with function. And basically the treatment is they do something called venesection. So you basically donate blood, but instead of storing it, they throw it away. And that can help with your symptoms. That can obviously contribute to low testosterone, because it can contribute to anything. So you say to these patients, well, do you want treatment for low testosterone? Have we just discovered the hemochromatosis? Has it just become a problem? Do you want to get that sorted first? It doesn't matter what your testosterone level is. If you feel great, you're probably not going to seek help, right? And then for those patients, yeah, we can start treatment. And I normally try and form a close relationship with their hematologist, or let them know, that sort of thing. Other comorbidities, another big one, antiphospholipid syndrome. That's quite a scary one, that. There's probably nobody here that has this. It's reasonably rare, but I've seen a few. And basically this clotting disorder predisposes you to clots. And I've had some people very young, 20, with catastrophic strokes with like long-term effects, that sort of stuff. Whether you do or don't have low testosterone secondary to that, whether it coexists, I'm not too sure. But those patients, you've just got to I think they pretty much have to go on gels personally. There might be a doctor that gives injections, but I'm not one of them. I'd want you to start on gels first. So yeah, other than that, I think I'm a believer in all medications could be a culprit, but I think it's best just to show me your meds list first. I think opiates are the number one. They're pretty bad. And then things like recreational drugs are pretty bad as well. Other than that, show me your meds and we'll talk about them.
Yeah. I'm always surprised how many medications people are taking. I see, patients from baby till 90 years old. A lot of people 50 plus, if you ask what medications are you taking, they have a whole list. Something to sleep, an antidepressant, something for their blood pressure, for their thyroid. The list goes on and on.
I think if you look for problems, you find them. Another one, you might have seen this yourself, is vitamin A analogs. Things like Roaccutane, stuff like that. That's got some 5-alpha reductase activity, I think, and it can give you lots of sexual dysfunction and things. And I've seen patients with that. Some of them have just had sort of acne that's so bad, they're saying, I know it gives me sexual dysfunction, but I can't live like this. And that's fair enough. So again, you see some patients on medications, you can't do anything about it. That's it. Chemotherapy is another one. They can't stop the chemo, can they? So it's that sort of thing.
A question in the chat box. Do you prescribe PDE5 inhibitors and peptides to improve sexual function?
Peptides? No. I'm interested in peptides personally. It seems to be quite a new thing that's happening, but I'm not an expert in it. But I do want to gain some knowledge in it, or I'm at least interested. So PDE5s, we prescribe them. What I say to patients, they're very cheap, to be honest, at cost price. You can get, and then, so there's sildenafil, that's Viagra. That's what I explain to patients. Everyone knows what that does. You take it, you get erection for a few hours, don't you? And you use it, and then that's the end of it. And there's also something called tadalafil, and I think the brand name for it's Cialis at the minute. So, and that works in exactly the same way, but it's got a longer half-life, and we give a lower dose. So the idea is you take it every day, and it's not to make sure you have an erection. We're not trying to teach you a lesson or anything, but it allows for a more spontaneous erection. So it allows you to facilitate an erection more easily, and you can also take a top-up dose. I normally recommend 5 milligrams a day, and you can take up to 20. So you can take a further 15 for that Viagra-like effect. And it's so cheap and easy, and it's a tablet. I just tell patients about it in my consultation. And then what most of them say is, thanks for letting me know. But testosterone can also contribute to erectile dysfunction and sexual dysfunction and things. Why don't we see how the testosterone goes? And if I need your help with the tadalafil later, I'll let you know. So in short, yes, we do prescribe them. I give patients the choice. There is some research out there. Now, don't quote me on this. I do a good job of explaining it, but I don't know how scientifically good a job I've done. But patients with cardiovascular risk factors, metabolic syndrome, diabetes, high cholesterol, that sort of thing, the patients need statins, those sort. It's been shown to lower all-cause mortality if you give PD5 inhibitors and testosterone, you treat all those things. So if I say for those patients who are diabetic as well, if type 1 or type 2 diabetic, I'd say really think about this. It might keep you on the planet a bit longer. Although I can't promise to make you live to 100. There's also been some research showing it can contribute to increasing testosterone a bit and lowering estrogen. The mechanism of that, I'm not too sure, so I don't really spend too long explaining that. The other thing to watch out for is if you're on any sort of nitrate medication, you can't have this drug. So it'd be called something different in every country, but if you've got heart condition and you're on nitrates, you can't have this. But we'll look at your meds list and your doctor will know this.
Related supplements. Is there a list of certain supplements that you recommend to every man coming in for TRT?
Not really, if I'm honest. I know there's things like this ashwagandha that's got a lot of traction behind it, and tonka ali and things like this. I say if you want to do herbal things, I'm not against it, but I think you need to pick herbal treatments or medication, really. Sometimes herbal stuff can interfere with medications, and neither your herbal doctor or supplier or your doctor is really versed on either one. I just not seen any evidence for it working. If it works for you that well, why are you seeking medical help? Just you can buy it over the counter and just take it if that's doing it for you. In terms of things like there's every kind of supplement out there, isn't there? I think the only supplement I'm a real fan of maybe a multivitamin and vitamin D, because we're pretty much all deficient in it. If you're not deficient in it, fair enough. Beyond that, a lot of the marketing stuff out there, I don't really buy into. I think if you're getting everything you need diet-wise, then you should be okay. Because remember, every time you eat something like cakes, you're not eating lean meat, fruit, veg, and stuff with all the high nutrient content in. You're eating cake. So, like, are you doing that to yourself partly, and that's why you need the multivitamins? I don't know. I try not to be closed-minded to things, but I do think there's a lot of people just trying to make money out of supplements and things. The peptides thing's interesting though, but it's not something I'm an expert on. But I think if you're going to research something that's new and cool that's out there, that's something to look into. Like, but yeah.
What are your thoughts on using finasteride or dutasteride for hair loss whilst on TRT?
Okay, please be nice to me in the comments section. Okay, like, you know, but don't take it. Go bald instead. If I had to tell you in 5 seconds, there's something called post-finasteride syndrome. So if you're watching this, you can look it up yourself. Anyone that's out there. But it's linked with irreversible suicidal thoughts, sexual dysfunction, and depression. That's harrowing. That'll ruin your life. And there's not really anything that can be done about it. There's some people who think you can get stuff that's for DHT, like something called Proviron. No doctors in the UK prescribe this. I don't think we even can. But that's supposed to be like help with DHT and things like that. But yeah, I'm unsure of the exact mechanism for it. But well, it's a 5-alpha reductase inhibitor. But like, I'm unsure why it's so long term in its effect. It does work. It will stop the hair loss or contribute to stopping it, but the cost is too great. Some patients will get away with it and be fine. But just so you know, 5-alpha reductase is expressed not just in your hair follicles, it's expressed in every major organ in your body. So what are you doing? Why are you inhibiting it? You must need dihydrotestosterone everywhere. It's doing something. I wouldn't. And to be honest, a lot of patients who talk about hair loss really don't want to lose their hair, and it means a lot to them. And I'm very sorry that I just personally, I won't be moved on the subject. I think it's just too big a risk, and I can't help you when it starts to go wrong, really. all I can say is stop taking it. I don't know what it's like in Belgium or other countries. There is an over-the-counter preparation called minoxidil that you can get.
Yeah.
It's supposed to like promote blood flow and help stop hair loss, that sort of thing. I'm unsure of the efficacy. I'm unsure how much it works, but it won't do any harm. The other thing people say to me is, what about topical finasteride? I can get it mixed with minoxidil. That's a product. Just don't touch your finasteride. I really can't help you if it goes wrong to any significant extent. I really can't guarantee things. It's not as simple as increasing your testosterone and you're out the woods. It's a really big problem. So I just wouldn't. So yeah, sorry guys.
Yeah, I was bold way before TRT and I couldn't care less. That's what I recommend to my own patients as well. As a dermatologist, I see a lot of young men, 25, 30, starting to lose their hair. And yeah, if it's in the genes, there's not so much you can do about it. You can keep on fighting it with minoxidil. Some really want to try finasteride, and some go to Turkey to have their hair transplants and so on. But yeah, it's a lifelong endeavor, and they'll never be happy. That's a pity to be. Yeah, I always say to young men, it's not a disease; it's just a natural evolution for a man if you're predisposed.
Yeah, and I say as well that people say, "Well, I'll lose my hair on testosterone." I say, "Well, if you were destined to, probably, because we're just putting back in what you didn't have." So if you were going to go bald, if you have no testosterone, you definitely won't go bald. I'll tell you that. But yeah, like there isn't much I can do, and it is sometimes it's a bit of an awkward point in the consultation. But there really is not much significant out there.
Yeah, if you don't have the genes, you won't lose it on TRT. But yeah, if you do have the genes,
I mean,
yeah,
hair transplants might work. I'm unsure about what testosterone does to hair transplants long term. You might get away with that. I'm not sure, but then you might just go bald again anyway. It's your own hair. I don't know,
the hairs on the back of your head aren't that sensitive for DHT. So if you do transplant them to the front, the hairs don't change. Just they will not fall out. But all the hairs just behind it will fall out. So you will have to need another hair transplant 5 years later. Yeah, it's the truth.
If that's what you want to do, that's what you want to do. But there's not really much I can. And I just say, if you're going to take away one thing from this whole talk, really, never touch finasteride. There are a lot of companies offering it out there. They want your money for the finasteride. I think any responsible clinician wouldn't offer it to you.
Few more questions, Andy. Do you prescribe or recommend pregnenolone and DHEA?
Yeah, I'm getting this a lot. I think it's in fashion. So I always, in this point in the consultation, I get the testosterone synthesis pathway out. So I think it's cholesterol, pregnenolone is very low down the list. I can't remember everything, but then it goes into this like grid of about 9 different molecules, and you end up with things like aldosterone, testosterone, progesterone, things like that at the end. That's your end product. Pregnenolone is just one down from cholesterol. So what are you trying to do there? How do you know that you're not just going to get more aldosterone and get high blood pressure? How are you going to adjust all of those chemical equilibrium to get to the bottom? That's very complicated. So I don't know where that's coming from. I can't actually prescribe it anyway. I don't even know how you get hold of that, like legally. I don't know. Unless there's a very niche reason why you need it, which certainly wouldn't come under what I prescribe for. So I'm unsure what patients are trying to get at there. I think maybe just as useful is, are you getting enough healthy dietary cholesterol? Then your body will do the rest. It will make the pregnenolone for you. You know, it's just one stage down. So I don't think there's anything. And DHEA is just not something we deal with. So I'd like to know if anyone says in the chat, like, what are you trying to achieve from that? Because I think a lot of patients tell me, I've just heard about this and that's it. But if anyone's got a reason, then I'd be really happy to hear it. Some of this stuff's come from the bodybuilding community. They do like a lot of weird and wonderful things. Some of them do some great stuff. I'm really interested in what some of them have done, just to be able to survive the training, basically. But it's not something we can really put into practice. That's just more of a personal interest. But I don't think there's anything medical we do with pregnenolone.
Yeah, I know, like DHEA in some countries, it's over the counter. and it's heavily promoted as anti-aging. So yeah, I have some men even in my practice. If I ask what they're taking DHEA. I always ask why. It's the only thing they're taking. They don't know about hormonal optimization or whatever. They just take it. Oh, I bought it somewhere online because of its anti-aging properties.
Honestly, I think if you're really concerned about anti-aging, train really hard. Train all the time. Train as smart as you can. Train as much as you can with the life that you have left. Obviously, if you're 70 years old, probably don't start powerlifting, or do it responsibly, but I think that's it. Like no matter what cosmetic stuff you've had done or something like that, you can't beat someone who's in shape. Someone who's really in shape in their 50s looks impressive, and there's nothing you can really say or do about that. And we've all been in hospital, met farmers, and you shake their hand, they can break your hand, and you're impressed by it, because they've kept active their whole life. I think physical activity is the biggest anti-aging thing, and looking after your diet and sleep is the second, just as important. I think anyone trying to sell you a product as anti-aging, I don't think they're being completely truthful with you, to be honest. And I debate them on the topic.
Yeah, I agree. Another question. While on TRT, does alcohol consumption or other recreational drugs affect your blood testosterone levels? Does not getting the full benefit, or just how your body is responding to the TRT treatment? You've already answered that.
Yeah. So, I basically asking if you can use recreational drugs or drink on TRT. No. I mean, look, anyone who does recreational drugs is an absolute state, like when they do them habitually. That's no secret. No one who even smokes cannabis, and people have got a pretty lax view on that, but we all know people smoke cannabis every day. They are not a perfect example of fitness. And, sometimes people quote, Nick and Nate Diaz, the UFC fighters and stuff. Yeah, they smoke cannabis. Yeah, they're also like triathletes and compete and podium pretty regularly. So unless you're going to do that, don't talk to me about the cannabis part as well. And how much are they really doing it and stuff like that? No to recreational drugs, basically. Yeah.
Mm-hmm. Why do clinics in the UK, such as the Ledger Clinic, treat patients based on their lab results and not symptoms?
I used to work for Ledger Clinic. We do both. So you need blood results to qualify for treatment, right? The consultation is to talk about symptoms. So I assume you're seeking help for low testosterone because you have low testosterone symptoms. Now, I don't work for them anymore, but I know the Ledger Clinic, they're pretty open and honest. I've not got really a bad word to say about them. I work for a company called the Eden Clinic now. And again, we've got the same sort of ethos. If you don't need the treatment, don't have it. But then why are you seeking help for it if you've got no symptoms? And then if your blood results are fine, why are we having the conversation? So I'm unsure what they mean about that. But the reason we look at blood results is if your testosterone is normal and your free testosterone is normal. We're a testosterone clinic, a men's health clinic. We don't treat other things. I've been sent blood results before when I was working for the Ledger Clinic, and I have said, this doesn't qualify for treatment. I think you should see a physician for the following, but I'm unable to help you. And I've done that before, but I think it's pretty common practice in the UK, and as far as I know, everywhere, that we need to see evidence of low testosterone on your bloods, and you book a consultation to talk about symptoms. That's what the consultation's for.
Mm-hmm. So if patients really have a lot of low T symptoms and they are still in the normal range but lowish, you still can treat them.
Yeah, I mean, I think the International Society of Sexual Medicine have a good sort of one-liner in their abstract or their guidelines saying you're allowed to offer a trial of treatment to anyone based on symptoms, which is a nice get out. But then if your testosterone's normal, I'd need a very good reason to treat. You would need to have like absolutely crushing testosterone symptoms that really scream testosterone symptoms, like, things that are quite unique to it, like changing shaving free, you lost your beard hair and things like that. That's quite abnormal. That really does have to be a testosterone thing. And then when it gets to that point, I'd probably want to talk to an endocrinologist. And to be honest, probably an endocrinologist that I know that's keen on the topic, something like that. So yeah, like I do treat people with levels that make most doctors a bit uneasy, but I'm not a cowboy with it. There's a reason I'm doing that. So I think the easiest way to explain it, we do hear everyone out, but I'm not there to try and get people on testosterone who maybe don't need it, or there's no salesman approach, because even if I did that, which I probably could easily do, I've now got to monitor it, and you're not going to feel as good on it. It'd be an absolute nightmare. Not a good one to pressure sell, to be perfectly honest.
What are your thoughts on using Proviron to lower a very high SHBG 75 to 80?
I'm not too sure lowering SHBG like artificially actually does anything. Now, I can't remember where. It was a very well-respected endocrinologist that said it. But I think they managed to lower SHBG and were testing lab values based on this, but it didn't do much to symptoms. And once I heard that, that was enough for me. And I just thought, okay, we're just going to treat the testosterone. I look at the SHBG to guide my further management, basically. So what you get sometimes is patients, if you hid their results from them. Now, I'm not saying it's everyone in this chat, but this is just for argument's sake. And you said, how are you feeling? And they said, fine. And you go, okay, your testosterone's mid-range. They go, well, actually, I'm not fine. Once they've seen the number, So I think there's a bit of that involved. I agree. If you do have a very high SHBG, you can feel quite symptomatic. I think we just have to increase the testosterone. Now, testosterone replacement therapy can actually lower SHBG. So if your SHBG is very high, I think we need to pay lots of attention to that once we start TRT, because it can go low, then your free testosterone goes high. Then it becomes this bit complicated to monitor your blood results, but that's kind of why you seek medical help. Let us worry about that, basically.
Can you see in the numbers if someone is using alcohol, or are the numbers the same since it's exogenous, or will they just not get the full benefit of symptom resolution?
Yeah, you can drink what you want. I'm not the police. I just trust that you won't. So can you see? Yeah, your gamma GT will be raised, and I think there'll be changes in your mean cell volume. But to be honest, I just believe you. Gamma GT can be raised by lots of things. Yeah, if you want to carry on drinking alcohol, carry on. But I'm telling you point blank, you won't get the same results of TRT. Think if you go on like a bender all weekend, how are you going to feel at the end of that? And TRT is not going to change that. And then when you're really hungover or something, your testosterone is not very high. Testosterone is very sensitive. It can really change in real time. And so, yeah, I wouldn't do it. If you want to drink, I'm not going to stop you. By all means, you can enjoy going out every now and then. I think that's pretty culturally acceptable to go out once a month, once every couple of months, that sort of thing, and drink to excess. I think that's pretty normal. I'm not going to be the doctor that says you can't and won't do that. But I think some people go out every weekend and finish work and have drinks with work and things like that. And I know a lot of these businessy jobs, they drink at lunchtime. And if you add all those units up, it's doing a lot of damage. I think just be in control of what you're drinking, basically. That's it. But no, I can't tell. And if you are doing it, to be honest, I'm not going to call you out on it. I just say, is there any lifestyle factors you can improve? You say no. That's it. Yeah, I'll just use what you're telling me.
Sure. Okay, Andy, we're almost 1 hour in. Let's round this up. Can you tell patients watching this video, or maybe later, how they can reach you in the UK if they want to work with you?
Yeah, so I work with the Eden Clinic. So you can just search for them. They've got an Instagram page. I've got an Instagram page. I feel really cool. I'm new. Hang on. No, I just need to look up and tell you. I'm not very big on social media. Hang on. But I suppose I need to change that. You can reach me through the Eden Clinic. So yeah, my Instagram username is Dr_Andrew_Tomlinson. You can reach me on that. If you do want to reach me on that, message me. I'll respond to anything, but bear in mind, I'm not going to get too clinical on Instagram. So I think the best place to contact is the Eden Clinic. We'll get back to you with anything. And yeah, just any questions you have. And that's all really. I think that's probably a better way to go. I think some people do consult the internet, do consult Reddit, and you just kind of at the mercy of what some people think. I think it's great for people who talk about their own personal experience, but I think that quickly spills into giving medical advice from an anonymous source online, which I'd stay well away from.
Yeah, sure. Okay, Andy. So I'll thank you very much for doing this and sharing your knowledge.
Thanks a lot. Thanks for having me. And yeah, that's it. Good to catch up sometime. And yeah, that's it. Keep in touch.
Okay. Thank you so much. And talk to you next time. Bye-bye.
No problem. Catch you soon, everyone.
Bye.